Good morning, good afternoon, good evening, as the place you are in. Welcome to Afomp monthly webinar. This is the 24th Afomp webinar in the series. We started in June 2020 the Afomp webinar, virtual Afomp webinar. Because of the COVID situation, in-person meeting were not possible, but the academic activities cannot stop. And therefore, Afomp took a step to start monthly Afomp webinars since June 2020, and regularly we are organizing. So this is the 24th Afomp webinar. In addition to Afomp webinar, Afomp is conducting Afomp school webinars every month since June 2021. And in this month, May, we have two Afomp school webinar, one special and one is routine one. So today's Afomp webinar is, the speaker is Dr. Joel Poder, who is from Sydney, and he will be introduced in detail by today's moderator of this webinar, Jeevanshu Jain, who is working in Mumbai. I will introduce her. The topic is very important and one of the oldest modality of radiotherapy before brachytherapy started. Brachytherapy basics to recent advances will be delivered by Dr. Joel Poder, moderated by Jeevanshu Jain. And just to introduce Jeevanshu Jain, she is currently designated as a medical physicist scientist C since 2019 at the Department of Radiation Oncology, Advanced Center for Treatment, Research and Education in Cancer at TREC in Tata Memorial Center, Navi Mumbai, India. Previously, she was a senior demonstrator during 2018 to 2019 at Department of Radiological Physics, SMS Medical College and Hospital, Jaipur. She is my old colleague in my department. She has done DPARP that is Diploma in Radiological Physics from Baba Atomic Research Center in 2015-16, MSc in Applied Physics, and during 2012 to 14 from Malviya National Institute of Technology, Jaipur. With this short introduction, I welcome you all for this Afomp webinar. I request you to please mute yourself and put up your videos so to get the good bandwidth. I hand over the floor to Jeevanshu Jain for carrying further proceedings of this Afomp webinar. Jeevanshu Jain, up to you now.
Thank you, sir. Good day, everyone. And I thank Sir and Afomp to give me the opportunity to moderate the current event. I welcome everyone to the monthly webinar of Afomp on brachytherapy, basics to recent advances. I also welcome our speaker for the day, Dr. Joel Poder, and the other dignitaries from Afomp who have joined us. With the advent of external beam radiation therapy, brachytherapy as a treatment modality took a back seat, but it is now re-emerging with new technologies and possibilities. Brachytherapy, for most of us, resonates with gynecological and prostate cancer and maybe intracavitary applications only. However, there are many more dimensions to it waiting to be explored. It started with the radium era, but now with iridium, cobalt, iodine, palladium, and many other isotopes available for a wide range of applications, be it the head and neck cancers, bone and soft tissue cancers, eye plaque treatments, esophageal cancers, the possibilities in brachytherapy are many. Brachytherapy is a very interesting branch of radiation physics, only it requires to be rediscovered. To give us an insight into the journey of brachytherapy and its recent advances, we have Dr. Joel Poder amidst us, a renowned expert in the field of medical physics and brachytherapy. Dr. Joel Porter is a senior radiation oncology medical physicist working at St. George Hospital Cancer Care Center in Sydney. He has extensive experience in multiple forms of brachytherapy, including LDR brachytherapy, in his last 10 years of medical physics practice. He has previously completed a PhD with the Center for Medical Radiation Physics, the University of Wollongong, where he developed an innovative system for end-to-end quality assurance and in vivo source tracking of HDR brachytherapy treatments of the prostate. Dr. Joel is also a long-standing member of the Australasian Brachytherapy Group Executive Committee and has published more than 30 articles in peer-reviewed journals covering a range of brachytherapy topics. It is a pleasure to have you, Dr. Porter, amongst us as the faculty speaker for this Afomp monthly webinar of May 2022. I request everyone to mute their microphones during the talk. The participants are requested to put their questions in the chat box, which will be answered at the end of the talk. I now invite Dr. Porter to deliver his talk on brachytherapy, basics to recent advances. Dr. Joel.
Thank you very much for the very warm introduction, and thank you for the excellent opportunity to speak here at these monthly Afomp webinars. I think it's a great initiative that Afomp is able to share these webinars with the community, and I feel very privileged to be able to talk to you all today on my favorite topic, which is brachytherapy. Just wanted to check that you can see my slides and that you can hear me okay.
Perfect. Yes, go ahead.
Yes.
Great,
yes,
thank
we're able
you.
to see.
So as I was alluded to in the very nice introduction, I'm here to speak to you today about brachytherapy, and I hope to take you on a journey from the origins of brachytherapy in the radiation oncology field all the way through to some of the more recent advances and where we might be able to see brachytherapy treatments heading in the next couple of decades. Brachytherapy is actually if you look at the word for brachy, which is actually derived from the Greek word close. So if you convert the word for brachy to the Greek word, you're thinking about close therapy. So I think that's really interesting when you think about the true definition of brachytherapy, which would be the placement of a radioactive source either close to or in or adjacent to a tumor that you're attempting to treat. So close therapy, I always think that's very interesting. We can go back to the origins of brachytherapy all the way through to 1896, when Henri Becquerel first discovers radioactivity. Dr. Becquerel actually found a mineral, which ended up being uranium, that would actually darken a photographic plate even if the plate was covered. He postulated that this mineral emitted some form of new kind of radiation that wasn't yet known, and he coined this term that basically he wasn't sure what it was. So it wasn't X-rays, but something new. In 1897 and 1898, Ernest Rutherford studied the nature of these unknown rays and that are emitted by the different minerals. He was able to classify the rays into 3 distinct types, and these ended up being called alpha rays, beta rays, and gamma rays. During this time, he also theorized the existence of neutrons and conceptualized what a nucleus might look like. Then in 1900 through to 1908, the Curies, both Marie and Pierre, discovered 2 previously unknown terms of radioactive minerals, and these were polonium and radium. And radium is really, truly important for the initiation of brachytherapy, as you'll see in the next few slides. And these 2 were actually the original couple to coin the term radioactivity. So we can trace the origins of brachytherapy all the way back to 1901. And as was graciously mentioned in the introduction, it is the oldest form of radiation therapy. So here I'm showing you on a slide a document, and it's in French. And unfortunately, my French is not very good, so I'm unable to translate for you. But in this document, you can find here the first documentation of radium being used to treat skin lesions for cancer patients. So we can trace the origins of brachytherapy back greater now than 120 years. Here's a photo that I'd like to show, particularly it's because it's all the way back in 1905, but also that it's from my home country in Australia, in the city down in Melbourne. So in this photo, you can see some patients holding essentially what is a brachytherapy applicator onto the lesions on their skin. And these applicators contained radium, and they were being used to treat these lesions. Here's some evidence again from the early 1900s of this technique that was called the moulage technique. And basically that involved placing these radium sources here in an array on the patient's skin. And you can see this gentleman here, he has a lesion under his eye. This technique was used here, and then you can see this lesion resolve. And this is really skin brachytherapy, and not too different in terms of the skin brachytherapy that we would use to treat today. In the 1920s, we saw the development of radium needles. So these radium needles were, as you can see on the screen here on the top left, essentially a needle that you could use to treat in some form of interstitial brachytherapy, and placed within these needles were some form of radium. And then that basically initiated the treatment of prostate cancer and gynecological cancers using these radium needles. So you can see here is an X-ray of radium needles being placed inside a patient. And here is a depiction of using radium needles to treat prostate cancer from 1922. So if you basically look back again to the early 1900s in the history of brachytherapy, you can also see the development of the number of methods and rules that we've all learnt about from the textbooks in our time and becoming medical physicists. So in 1914, we saw the development of the Stockholm method for gynecological brachytherapy. Then 5 years later, the Paris method was developed. Some two decades after this, the Manchester-Patterson-Parker system was developed. And then in the early 1930s, also the Paris system for interstitial brachytherapy. And these types of methods and rules that we still learn and talk about today and form the basis of brachytherapy implants all the way through to the 2000s. In the 1960s and 70s, this really saw the end of radium use, mainly due to radon contamination, but also due to radiation protection issues. Back in the 1960s and 70s, there was no afterloading. A lot of the radiation sources and the radium needles were placed manually, either on or inside the patients. There's radon contamination due to the decay of the radium. So there was a lot of radiation protection issues that were beginning to be recognized. Luckily, at around this same time, there were a number of alternative methods and isotopes that were being developed to move away from radium. Around this time, really, in the 1960s, saw the basis for modern brachytherapy beginning to show. In 1934, we saw the discovery of a number of different artificial radioactive isotopes. 1958 actually saw the discovery or the beginnings of iridium-192. So here you can see all the way back in 1958, iridium-192, there was evidence that it was potential to be used for brachytherapy treatments. However, as we know, iridium-192 is a high dose rate source with a relatively high effective photon energy. So it's not really an appropriate source to be used for manual afterloading. So it's not so surprising that in this next decade, the development of the afterloading concept became available. And in that time, again, in the 1960s, we also saw the development of three-dimensional dosimetry and the fundamental rules of dosimetry that we're beginning to use in modern brachytherapy techniques. So here's in 1962, you can see an image here on the top right of the screen of the first remote brachytherapy afterloading unit. The device had a single channel. The source could only be driven a very small distance within this single channel, and the radioactive isotope used was for cesium-137. If you fast forward to the modern day unit, remote brachytherapy afterloading units, the modern brachytherapy units often contain iridium-192. However, there are some units that also use cobalt-60. There's image here in the middle, the Elector Flexitron remote brachytherapy afterloader, and on the bottom right here is the Varian Bravos system. And you can see the difference between how far the technology has evolved. In 1962, we had a single channel. In the 2020s, we have up to 40 channels that the source can be driven through. And we know that we're able to stop the source for multiple different dwell times and multiple positions within each of these channels. So there's been a really huge leap in the technology over the first 60 years of remote brachytherapy afterloading. Just a slide here to show the development of computerized treatment planning. So a lot of these images were from this publication from the Journal of Contemporary Brachytherapy. So I'd refer you to that for a very interesting read on the use of computerized treatment planning in brachytherapy. The bottom left here shows an image from Memorial Sloan Kettering Hospital in the early 1960s, and it's a percentage depth dose curve here for one of the radioisotopes that was used in the center at the time. Over on the right is also an image from the Memorial Sloan Kettering Hospital, and here they're actually drawing isodose lines manually using this punch card. And the slide in the middle here shows how the dose from multiple different dwell positions may be added to produce an isodose curve. So this is a manual calculation. So this is really a nice article here that I'd like to refer you to get the history of computerized treatment planning for brachytherapy over the years. Now, if you think about the manual calculations that I showed on the previous slides, and here is some examples of what a modern brachytherapy treatment planning system might show you today. So the images here on the left are for what you would see for a typical pear-shaped dose distribution used for cervical cancer brachytherapy treatments. We have the intrauterine tube and now two ovoids here on the coronal slice. And we can actually take a CT scan of the patient with the applicator in place, and we can do a full 3D dosimetric calculation of the isodose distribution created by the treatment plan. We have organs at risk and targets that we can contour, or the radiation oncologist can contour, and we can calculate three-dimensional dose volume histograms to assess the quality of the plan. Similarly, here for prostate, here's an ultrasound image of the prostate taken transrectally. We have some iodine-125 seeds in this case that were planned to be placed in different positions around the prostate. We have quite nice definition of the prostate on the ultrasound image. We have not quite nice definition down here of the anterior rectal wall. We have a urethra going through the middle. So similarly to what we can see for the cervical cancer treatment, we can have three-dimensional dose distributions and dose volume histograms that we're able to assess the quality of the treatment plan. So again, we've come such a long way in only 60 years of brachytherapy treatment planning. I think the other driver of the increased quality of brachytherapy treatments over the last years has been the use of ultrasound guidance for needle and catheter insertion. So I'm showing here just a diagram on the left of the setup for what you would do for a prostate brachytherapy treatment for potentially, say, iodine-125 brachytherapy, low dose rate prostate brachytherapy treatment. So the patient lays on the operating theatre bed. We're able to use this device here called a stepper, which holds our ultrasound probe as well as this needle grid. And we can use this ultrasound probe to place into the patient transrectally and obtain these nice images of the prostate that you can see here on the right of the screen. Then we're able to do some calibrations as a physicist to ensure that this grid that you can see here on the right of the screen matches this physical grid here that is placed over the perineum of the patient. And then we can use this grid essentially to guide the placement of the needles to within, I'd say, the accuracy of 1 to 2 millimeters at least inside the prostate. So really, we're able to utilize this imaging technology to be able to deliver really accurate and high quality treatment plans to the patients using ultrasound image guidance. In terms of our dose calculation formalism, the current gold standard, or the current standard around the world, is the use of this TG43 dose calculation formalism. The origins of this formalism can be traced back through to the original AAPM Radiation Therapy Committee Task Group number 43 report, which was published in 1995 with Ravinder Nath as the first author of this publication, and then a revision of the protocol, which was published in 2004. So basically, this type of dose calculation formalism uses two different equations. You can see these equations here in the top right of the screen. This equation at the top here is a point source approximation, and the equation underneath is a line source approximation. So it uses inputs such as the air Kerma strength of the source. There are some parameters such as the dose rate constant, the anisotropy function, and the geometry function, as well as a radial dose function. I'll refer you to these reports if you're not already familiar with them for an in-depth description of how the dose calculation formalism is carried out for brachytherapy. But this has really been the workhorse of brachytherapy treatment planning since its origins in 1995, and it's really still the standard brachytherapy treatment planning algorithm that is used today. So the terms that are used in the equations here can be seen in this diagram down the bottom. So it uses the active length of the radioactive source as an input parameter into this geometry function. The radial distance r is defined as from the center of the source along the transverse axis to any point in space p. And this theta here basically is the angle of this line from that point to the center of the source from its transverse axis. That's just theta here. So basically, we're able to use this formalism here to calculate the dose to any point in space, and then use that then to obviously calculate a full 3D dosimetric grid for plan evaluation. So what are some indications that brachytherapy can be used for? We have obviously gynecological tumors, prostate cancer treatments. It can be used for areas of the head and neck, such as the base of tongue and the tonsils. Breast brachytherapy treatment is a treatment that we offer at St. George. It's probably not as common around the world, but is a very effective treatment for early stage breast cancer. Brachytherapy can be used for treatments of the anal canal very effectively. The penile cancer treatments as well. Then we have esophageal and bronchus treatments. Again, a very nice form of treatment for both of these two, especially for those patients who have had previous treatment in the area. Because of the rapid dose fall off that we're able to achieve with brachytherapy, we're able to then retreat some of these areas that we may not be able to with external beam radiotherapy. As you've seen from my first few slides, brachytherapy can be a very effective form of treatment for the skin, and it is still used for that to this day. We're able to use it for various soft tissue sarcomas and also rhabdomyosarcoma patients for pediatrics. And that's also another technique that's offered in Sydney at Westmead Hospital and is proven to be very effective. So I'd just like to touch on the top two indications from my previous slide, that being cervical cancer and prostate cancer. So I've taken these Kaplan-Meier curves here from this publication from the group here at Princess Margaret Hospital. And basically they looked at trends in utilization of brachytherapy in cervical cancer patients in the United States. And you can see from the Kaplan-Meier curves here, so basically we have cancer-specific survival and overall survival from the cohort of the patients that were looked at in this study. And you can see that basically the significant improvement in overall survival, as well as cancer-specific survival when brachytherapy was utilized as a portion of the treatment. So for the cohort of patients who did not have brachytherapy, they received an external beam radiotherapy form of boost to the cervix and to the uterus, and not brachytherapy. So external beam radiotherapy was substituted. And basically what we have here is unequivocal evidence that brachytherapy should be utilized as part of the treatment technique for cervical cancer patients. There's been an excellent number of the clinical trials that were performed as part of the EMBRACE studies. So one of these is the retro EMBRACE study for some of the publication which I've shown on this figure here. And you can basically, again, just show that, this very large clinical trial with a number of multi-center clinical trial, and basically looking at the local control, pelvical control, cancer-specific survival and overall survival. And you can see even out to 5 years when brachytherapy is used as a portion of the treatment, that the local control is remaining at close to 90%, even at 5 years from the patient's treatment. So it's just unequivocal evidence, again, that brachytherapy is an essential part of this treatment for cervical cancer. I'd like to also touch on prostate cancer. So many of you may be familiar with the ASCEND-ERT trial, which is basically an analysis of a clinical trial comparing low dose rate brachytherapy boost to dose escalated external beam boost for the high and intermediate risk prostate cancer patients. And I've just presented here on this slide basically the survival endpoints. So what we're looking at here is the proportion of patients who are free from biochemical progression on this Kaplan-Meier curve, and you can basically see at about 4 years' time the separation of these two curves. So the patients who received a brachytherapy boost, obviously those who were free of biochemical free progression remained at around 85 to 90%, even out to 10 years past their treatment. Whereas if you compare that to those patients who received an external beam boost, that's right down at 60% at 10 years. So one of the criticisms of this form of from this trial was that basically the patients who also received brachytherapy boost, their quality of life indicators were much worse than those who received the external beam boost. So I'm showing two curves here. The first one being the incidence of grade 3 or higher urinary morbidity, and the one underneath was the GI morbidity. So again, brachytherapy in red and the external beam in black, and you can see basically not much difference in terms of the gastrointestinal morbidity, but much higher incidence of genitourinary morbidity for those patients who received brachytherapy compared to external beam. So the people who performed the trial did a really great analysis of the events. So they looked at basically in this trial, it was strictures that accounted for approximately half of all of the grade 3 GU events in the LDR boost cohort. And basically what they did find was that a lot of these strictures were occurring in the membranous urethra. And that's around the area of the prostate towards the apex, or the most inferior portion of the prostate. And part of the hypothesis was that there was not a really great technology of transrectal ultrasound imaging that was being used. And that was actually resulting in an increased area, or an over-treatment of the area around the apex that was being treated for those patients who were receiving boost, and therefore too high of a dose that was being given to the membranous urethra, causing these strictures. So there was a significant volume of normal tissue inferior to the prostate that was being included as part of the treatment volume. So they're suggesting that technical changes in the future may have the potential to reduce these incidents of severe events, while also maintaining or even gaining in biochemical free progression. So they're advocating for the use of magnetic resonance imaging for treatment planning to get a nicer vision, a nicer view of the prostate. But I'd argue even really more a modern transrectal ultrasound imaging would actually be sufficient to able to curve this. And they actually do mention that as well, exploiting the improved image quality of newer generation ultrasound equipment should allow a reduction in dose to the membranous urethra. So despite the fact that we've got potentially increased amount of side effects here, I think, with increased technology in the use of prostate cancer brachytherapy treatments, we're actually going to see some really great results coming through in the next 10 years or so. And I'd just like to show also here this special issue from the American Society of Clinical Oncology. And they're basically advocating for the use of brachytherapy for patients with the Gleason 7 score, for low to intermediate risk prostate cancer patients, that these patients should be given brachytherapy boost. And for high risk patients receiving external beam radiotherapy and androgen deprivation therapy, brachytherapy boost should be offered to all eligible patients. So you can see here that we've got pretty strong consensus from the American Society of Clinical Oncology that brachytherapy boost should be offered as part of the prostate cancer treatment. So now I'd also like to go on to talk about some future directions of brachytherapy. So one of the future directions that I'd like to discuss, which is maybe not so much in the future, but what we can potentially see coming through in the present now is the use of a more modern dose calculation algorithm. So as many of you know, with TG43 dose calculation algorithm, it suffers from the assumption that all of the voxels that are used in the algorithm are made up of water, and that the boundary that is being used is basically an infinite water boundary. Basically what the American Association of Physicists in Medicine have come up with is a new type of model dose calculation formalism, and that's basically taking into account the densities in each of the voxels. So I've got slides here from 2 different publications just to give you an idea of what these model-based dose calculation algorithms might show relative to a more traditional TG43-based algorithm. So this first slide up here, a figure up here from Brachytherapy journal published in 2017, looking at a cohort of gynecological patients and recalculating plans with the new modern TG186 dose calculation algorithm. And you can see for the cervical cancer patients for the high-risk CTV here, very minimal change really in the dose volume histogram for the number of patients that they looked at. And even here on the right for the organs at risk, you can see differences in the rectum, the sigmoid colon, and the bladder. And most of the differences are looking here at the bladder. So we're expecting maybe slightly lower doses relative to what we were used to be looking at with the TG43 dose calculation algorithm. The second figure, which I'm also showing down the bottom here, is from our team at St. George, led by Andrew Howie. This study looked at the differences in dose calculation, dose volume histograms from the TG43 algorithm relative to the new TG186 algorithm in the electrobrachytherapy system known as ACE. And what you can see for the 120 patients that we looked at about a half to 1% decrease in the V100% of our target. And if you look at the D90 as well, you can see some differences. So this is basically the percent difference from TG43. And there is a decrease in the dose to these structures. So while these algorithms are now available in the brachytherapy TPS, it's not recommended to be using these algorithms clinically just yet. We're still in the data collection phase. So if you do have these algorithms available, I'd encourage you to do some studies looking at the patients that you have as part of your your treatment planning to recalculate the dose with the more modern algorithm and publish those results, because it's the more publications we can get, we can then move towards using these brachytherapy modern dose calculation algorithms clinically. I'd also like to discuss the use of advanced imaging in the future of brachytherapy. So particularly the use of multiparametric MRI or PET PSMA imaging, particularly for the prostate, where we might be able to integrate these advanced imaging techniques into our treatment planning to look at subvolumes within the areas that we're trying to treat. So just as an example, there's this phase 2 clinical trial that's been published in the last 2 years, looking at dose escalation to intraprostatic lesions that were identified on multiparametric MRI imaging. And what this study did was that they took these images. So you can see we have a T2 weighted image here, a diffusion weighted imaging, and then an ADC map derived from the diffusion image. And you can see on the right, the patient's left-hand side here, there's this lesion within the prostate. And what they did was they looked at fusing these MRI images to their planning transrectal ultrasound image, and then they were able to boost up the dose to these dominant intraprostatic lesions. So the image in the middle here basically is the dose distribution on top of the transrectal ultrasound image. And you can see the higher dose regions here that are being highlighted right over the top of where that intraprostatic lesion was identified on the multiparametric MRI. Another nice, interesting recent advance in the field of brachytherapy, which is here's an example of a MRI conditional afterloader. So basically what we have is a remote brachytherapy afterloader here that is able to be used inside of an MRI suite. So that what this particular study looked at was if we do implant some needles in this tissue here, which is a phantom, and basically can we actually treat and image, or can we actually image and implant the needles at the same time? So what we have is real-time MRI guidance as the needles are being implanted, but we also have treatment ongoing while we're imaging the phantom. So the two images down the bottom here, what you're seeing basically is this catheter that's being placed inside the phantom, and the same here in image B. And then here's some dwell positions that are being planned within this catheter. And this dark spot here in the middle is actually the radioactive source that's stepping through the phantom at that particular time. And what that's doing is creating an artifact in the MRI image. And that MRI image can then be used to track the position of the source as it steps through the phantom, or hopefully in the future, the patient in real time. I wouldn't be talking about the future of radiation oncology if I didn't mention artificial intelligence. There's been a number of studies in recent years that have looked at artificial intelligence for assisting in contouring in brachytherapy. So this study from the Medical Physics Journal here shown on the left is looking at the use of a particular deep learning algorithm to contour MRI structures for gynecological brachytherapy patients. And there's a similar study here from last year in the Green Journal looking at, again, artificial intelligence to contour structures on CT for gynecological brachytherapy. So you can see it's performing quite well. I believe from this slide, the yellow is the artificial intelligence contour, and there's a red contour underneath here, which is the manual contour. So you can see for a number of these particular images that the two contours are essentially indistinguishable. What's also really nice and is actually unique to brachytherapy is the use of artificial intelligence for catheter reconstruction. So many of you who have actually performed catheter reconstruction either on an MRI scan or on an ultrasound scan, that it's not really a trivial task and does take a lot of time. So there are a number of studies that look at using deep learning to assist in catheter reconstruction for both gynecological and prostate brachytherapy treatments. So there's this study here on the left-hand side, which is applied to MR images for gynecological interstitial brachytherapy. And I've just included this figure here, which basically shows the difference in the deep learning assisted algorithm catheter reconstruction relative to a gold standard, which is essentially the average of a number of users. And you can see the mean error was approximately 1 millimeter, and that 98.3% of the differences in the AI versus the user were less than 2 millimeters. So it's doing quite a good job. I wouldn't say that it's 100% there ready for the clinic just yet, but potentially at some point in the future. I'd also like to show on the right-hand side here a very similar study applied to prostate cancer treatments using MRI. And you can see in image A here, we have some dark spots around the prostate, which are basically where these needles have been placed. And then this AI algorithm has identified these positions here on the scan. And you can see that there's some masking and binary image creation that's being done as part of the algorithm. And it's showing where these needles are being identified. And again, we have a method that's compared to some gold standard, which is usually some user input. And we have a nice histogram that's peaking around a value of 0 here, which is great. And majority of these errors, especially in the tip area of the needle, which is the most difficult to identify, are all around the 0 to 1 to 2 millimeter range. So again, probably not quite ready for clinical rollout, but not too far away either. We also have some other advances looking at the use of electromagnetic tracking in catheter reconstruction and QA. So there's a very nice study here out of a group from the Netherlands looking at the use of an electromagnetic tracking system for treatment verification in pelvic brachytherapy. So I'd like to identify a few things on the slide here. We have a phantom that's placed on the bed. We can see our remote brachytherapy arc, and it's connected to some catheters that are placed within the phantom. We have this PC over here on the left, which is our electromagnetic tracking PC, and it's connected to this which is essentially a electromagnetic field generator here that's placed over the top of the phantom. And basically what happens is you can connect an electromagnetic sensor to your needle or to an extra stylet that will go inside the needle, or potentially even to a channel within your brachytherapy remote brachytherapy afterloader. And then what you can do then is run that stylet, or you can run that channel through the needles, and you can actually do some quality assurance on the reconstruction of your catheters and compare that to what the electromagnetic system shows. And that's what they did as a part of this study. And you can see they tested it in a number of environments with different levels of electromagnetic interference. And the residual error between the user input versus the electromagnetic tracking input was much less than 1 millimeter for basically all of the different environments, which is really encouraging. In terms of brachytherapy treatment planning, one of the really nice things that we're starting to see come through is the use of multi-criteria optimization. And that's becoming standard in the external beam radiotherapy world. But we're starting to see it come through now in the brachytherapy environment. And basically what these systems are doing is they're creating thousands and thousands of different treatment plans at once. And it's coming in the period of a couple of seconds, essentially. So we're running an inverse optimization, and there's what the system will create is a number of different plans. And the output is essentially what you can see here on the right, where you have your target, your urethra, bladder, and rectum, for the example for prostate. And what you can do is grab these slider bars. So you basically, if you say, I want to increase the coverage on the target, you can increase that, and it will choose another plan for you that has a higher coverage. But basically what you're going to have as well is a trade-off, because as you increase the coverage, the dose to your urethra might also increase, or the bladder, for example. So as you slide across the target, then basically you might see the dose to the bladder increase. So it's just to show the user the trade-off that's happening here. But there's been a number of studies that have been done, and this is just one from the group in Laval, from Luc Bellieu and his group, that have showed that the standard inverse optimization versus the multi-criteria optimization. And looking on the right here is basically the difference in the quality of the plans that are produced. And you can see on average, we're seeing an increase in the target V100%, a significant decrease in the dose to the urethra, essentially the same dose to the bladder and the same dose to the rectum. So for the same amount of an extra amount of coverage, we're seeing a lower dose to the urethra and no change to the dose to the bladder and the rectum. And these plans are created in a matter of seconds, rather than going through a manual or an inverse plus a manual optimization technique. Some other exciting developments to come out of Canada from Shirin Enger's group are the use of dynamically shielded applicators. So basically what we have in this case is an intrauterine tube that has an inner rotating shaft. And within that shaft essentially is a shield. And you can actually rotate that shield around to direct the direction of the radiation that's being emitted from the brachytherapy source. So I believe in this case, they looked at a number of different radioisotopes. So they looked at iridium-192 and selenium here and yttrium. And basically they were able to use an inverse algorithm to come up with a optimal configuration of the shaft as the source steps through, and they could rotate around and direct the emission of the radiation in separate and different directions. So I'll just point your attention to the image on the right here, which shows your target, which is this area in red that I'm showing it with my cursor. And basically we've used a conventional treatment with just this single intrauterine tube. You can have the 50% isodose line that's covering the target. If you use your rotating shielded applicator with an iridium-192 source, you can see, potentially like we're getting a bit of an increase in the volume of the 100%, it's covering the target. If you can, and then looking at the application of this with the two different isotopes, and you can see if you go look at the yttrium value here, we're almost getting complete coverage of the target with this 100% isodose now, and we're actually minimizing the dose to the bladder. So if you compare the conventional dose to the bladder here versus what we're seeing down here on the bottom right, we're seeing a huge increase in plan quality. And what a really nice application of this might be is for a gynecological treatment that you need to minimize the number of interstitial needles that you might be required to use. And then another topic, which I'll go close to closing off on, which is the use of basically in vivo dosimetry or in vivo source tracking in the field of brachytherapy. So again, I'd like to point your attention towards this article that was published 2 years ago in the Journal of Physics and Imaging and Radiation Oncology. And this is a reviewed article on the use of in vivo dosimetry and brachytherapy, and gives some directions and future requirements for implementation of this type of technique into brachytherapy. So what am I talking about when I talk about in vivo source tracking? Essentially, it's placing a flat panel detector or a 2D array of detectors beneath the patient while they're getting their brachytherapy treatment delivered. So what will happen is, you can see, direct your attention to the figure in the middle here, is the source is stepping through the catheters. So while it's in this dwelling in this position, the catheter here, it's emitting radiation to treat the target. But the detector system below the patient is also detecting the radiation that's being emitted from the source. And what you can do is basically you can use the difference in the dose detected by each of the dosimeters in the array, and you can actually use this as input into a source tracking algorithm. And what you're able to do is actually reconstruct the position of this source in 3-dimensional space. So a number of these systems are now, in use in the research space around the world. And this review article actually provided some recommendations on how things could be rolled out clinically. They recommend the use of in vivo source tracking, which is this image you can see here. But this is a really nice figure because it shows that as we increase the clinical relevance of the in vivo source tracking device, there is also an increase in complexity. So if we can have a dwell time measurement as well as a dwell position measurement, we're able to actually recalculate a 3D dose calculation, but really we can't do a DVH calculation until we get some real-time imaging from the treatment. So one way that we might be able to do that is if we could integrate one of these source tracking devices, for example, with one of those afterloaders that could be used during an MRI imaging. So we have real-time imaging and in vivo source tracking at the same time. And really that's the gold standard of treatment verification for HDR brachytherapy. So now I'm going to finish off with giving you potentially what a brachytherapy treatment may look like in 20 to 30 years from now. I think we may have real-time image guidance, whether it be from MRI or transrectal ultrasound. We'll have the use of advanced applicators, such as shielded applicators, which I showed you a few slides ago. We're also going to have AI-assisted catheter or applicator insertions. So while we have this image guidance and we're placing in our applicators or our needles or catheters, we may have a computer algorithm that's helping us place these needles in the most optimal position in order to achieve the best plan. We're going to be using advanced imaging such as multiparametric MRI to boost dose to the higher grade disease within the clinical target volumes. We're going to have AI-assisted real-time contouring and catheter reconstruction. So what we may have is, as the image has been created, straight away our AI algorithms are going to be contouring those in real time. And as we implant the needles, we're actually going to have a real-time reconstruction of that needle as it's placed. We may be using multi-criteria optimization in order to come up with the best plan. We're going to have automated QA. We may have electromagnetic tracking for catheter position QA. In vivo treatment verification along with real-time in vivo imaging in order to make sure that the really complex plan that we've just created is going to be delivered accurately. And that is my vision for the future of brachytherapy in the next 20 to 30 years. I'd like to thank you for your attention during my talk today. And I'd just like to end with showing you the photo from our St. George Cancer Care Centre here with the sun shining over us in Sydney. Thank you for your attention.
Thank you so much. Thank you so much, sir, for this very interesting and insightful presentation. And specifically the future, the dimensions that you have highlighted are really, an eye-opener for us, because most of the centers, I guess, in our country are still into the intracavitary and gynecological phase, and we have a long way to go to reach where the future is. However, we have a few questions in the chat box, so I would just like you to answer them. So one of them is related to the point A, and that is, how do we address the issue of point A in the Manchester system, when they are not equidistant from the intrauterine axis? How do we address that situation? You're muted, sir. You're muted.
Thank you. It won't be the last time I make that mistake. So my understanding with point A is an applicator. It's an applicator specific point. So if your intrauterine tube is not going straight through the patient, your point A should be moving with the intrauterine tube. So I'd be happy to kind of expand that offline. If the person who asked that question wanted to contact me via email, I'd be very happy to answer that one offline as well.
So the next question is related to TG186. So we have two questions and I'll just club them. So the first one is a basic question, like what is the difference between TG43 and TG186? And related to that only is that why has it not been implemented even though it was published like a decade ago? So is it like a very complex kind of an algorithm, or is it like it has no clinical significance? So what is basically the reason that it has not been clinically implemented till now, even though it was published long back? So starting with the difference and then...
Yeah, great. So basically, as I mentioned during the presentation, the TG43 based algorithms assume dose to water in all the voxels. So it's not taking into account the different densities of any of the tissues that we're treating. It's assuming everything's made from water. And then basically there's no body interface that has air outside. So with the breast, for example, it assumes that water is completely surrounding the body contour as well. So with the TG186 algorithms, they're more like the modern treatment planning dose algorithms that you see in your external beam radiotherapy systems. So a lot of them are, for example, the ACE algorithm, it's a model-based dose calculation algorithm, and it takes into account those densities. So I'd encourage you to go have a look, the white papers that were published on these algorithms. The one from Brachytherapy, the one from Electo is called ACE. And the one from Varian is called Acuros. And basically they're taking into account the different densities. And there's a number of different ways you can do that, which probably leads into my answer to the next question, which is why hasn't it been clinically implemented yet? There's basically, we have to be very careful with how we roll out these new algorithms, particularly for brachytherapy that's used around heterogeneous regions. So you may have seen from my slides for the breast cancer patients where we saw 1 to 2% change when we went from TG43 to TG186. And what we need to remember is that these prescriptions that we're using in brachytherapy are based on TG43 dose calculations. And the organ at risk constraints that we're seeing are also based on these TG43 algorithms. So it's not really appropriate to begin using a TG186 algorithm without taking into account the change in dose. So we maybe need to think about changes in prescription or changes to our organ at risk constraints. And basically, in order to, before we can do that, is we need the data. So that's why I was really trying to encourage all of you who are listening, if you do have these TG186 algorithms available in your department, is go and perform a study on some of the patients in your TPS, go back and recalculate the plans with your algorithm and get a bit of an understanding of how the dose is going to change and publish it, because it's definitely an area of need. And before the brachytherapy community moves to using these algorithms clinically, we need the data to actually show what the difference is that we're going to expect.
Okay, thank you. Continuing the discussion on TG186 itself, there is one question that were there any phantom measurements done for TG186? And actually, I also have a question because we are in the process of commissioning TG186 at our clinic. So, I mean, we're in the process. So the starting point is where we're like, how do we go about it? Like the commissioning process as well as the quality assurance, because this would require a quality assurance too. So if you could give some insights on that, and if there have been any phantom measurements done, if you could share the results that you observed.
I'm not aware of any phantom measurements, I'm sorry, but I know basically the way that the TG186 group is recommending that you commission these algorithms, there's basically, if you go, I can't remember the website off the top of my head, I'm sorry, but there is a standard brachytherapy source model. So it's not vendor specific, it's not an elector source, it's not a variant source, it's just a generic source model that the TG186 group have created. Now they've created this generic source model, and each of variant and elector and the different brachytherapy vendors are actually allowing you to input this model into your TPS. And what's been done is that there's been a number of Monte Carlo simulations that have been performed with the different Monte Carlo algorithms, so GANT4 and XNRC and the others. And so what we have is a number of standard dose distributions that have come together from the average of these Monte Carlo simulations. And what the group's done is then benchmarked these dose calculations versus the Monte Carlo models. And so basically, as part of the commissioning, what you're required to do then is import this generic model and recalculate a number of different scenarios. So I believe there's 4 different scenarios that range from something very simple, such as like a large water phantom with a single dwell model, to then moving close to an air interface and that type of thing. And then basically you can recalculate in your TPS and compare that to the reference dose distributions that have come from the Monte Carlo algorithms. And so this is relatively well described in the TG186 document. There is a new document coming soon with more different scenarios, and that will also have a increased guidance on how to do this as part of your TPS. But again, people that aren't sure, feel free to send me an email. I'm happy to point you towards the right documentation and that type of thing.
Thank you. That would be really helpful. One question is that we have manual contouring and AI contouring, I mean automated contouring. So which one should we rely on? Which one do we have more confidence in? That's one of the questions we have. Yeah. I think that's in every dimension of radiation oncology, that whether to rely on automation or to rely on the manual workflow. So what is your take on that?
Look, that's 100% correct. I mean, the way that my philosophy that I approach these automated contouring algorithms is that I think it is very fast to give you a really nice starting point, but I think that the level of the algorithms are at this point, it would still require some user input to go through and at least check the quality of that contour and perform any modifications that you see fit. I think at some point in time, the algorithms will get to a point where they can probably be completely trusted, but I don't think they're there yet. And they do require some user input to check these. That's my philosophy at this point.
Okay, thank you. One more question related to the intensity modulated brachytherapy. So whether the patient will be comfortable with a rotating applicator, that's one of the concerns of one of the participants. So if you could just share, and what further implementation is there in this particular direction? Like what can we look forward to in future for the applicator development?
Yeah, as far as I'm aware at this point, a lot of these studies that have been done have been simulation based, so a lot of Monte Carlo work. I know Dr. Engar in Canada has been working on her own treatment planning system that is able to use these dynamically shielded applicators as part of the treatment planning algorithm and the system. So again, it's all conceptual at this stage, but I think it's a really exciting development that could see the input into the clinic using a less number of needles, which is obviously for the patient. I think it could be a concern, and obviously there's more rotating parts, and there's more likely things that are going to go wrong. So I think if we were to use these, we're going to need some extra verification, and I think that's where in vivo source tracking and in vivo dosimetry could play a part.
Okay, related to this itself, sir, there is one question that how do we mitigate the chance of a mechanical failure in this rotating applicators, because there are chances of the mechanical failure happening. So are there any mechanisms to mitigate that?
I think not. I couldn't answer that question. I'm sorry. I'd have to probably refer to the paper just to give you a strong answer on that.
There's one question that, is there any recent development or any efforts in moving from air karma strength measurement in air to direct dose in water medium in brachytherapy dosimetry?
Not that I'm aware of, I'm sorry, no. I think it's still all air coma strength that is the current standard. And I haven't heard of any movements away from that.
The last question that we have here is to verification of brachytherapy on Monte Carlo simulation, can we use gamma index or GPR instead?
I think gamma index would be great. You know, I think a gamma index potentially with a 1%, one millimeter, something along that lines, when you're comparing like a Monte Carlo versus a treatment planning system, that would be really great. I think that would be a good approach.
Thank you so much. We do not have any more questions, although I have a very short question if you have time. What is your take on image registrations in brachytherapy with the in situ applicator? Is there any, I mean, what's your take?
Image what? Sorry, it cut out a little bit there.
Image registrations, like whether you go for deformable or a rigid registration and the various kind of registrations available. What is your take on that? Because with MRI coming into picture, CT MR or ultrasound MR registration becomes one of the key factors.
Yeah, look, I believe image registration in the field of brachytherapy it's a very big unmet need. I think it's very difficult, but also very important, as you mentioned. So I'm hoping in the next few years we see a lot of research go towards this space, because I think it really could enhance the field of brachytherapy by, you know, including those multiparametric MRI images or including MRI images directly in the gynecological treatment planning. So yes, I think in terms of the rigid versus deformable, I'm not sure that deformable image registration is there just yet, especially when we're using multiple modalities like MRI and CT. But, you know, I think hopefully the research field can put a lot of efforts towards that area in the next few years, and we can move towards using that clinically. I think that would be amazing.
Thank you so much for this very interactive session. And I also thank all the participants for their keen interest. And thank you so much, Dr. Joel. And I now hand over to Chokley sir for the further proceedings. Thank you so much.
Thank you, Jeevanshu. Thank you, Joel, for a wonderful talk. And the amount of questions and the discussions shows that people are very much interested in brachytherapy. It is not going down. It is one of the important modalities. Yes, it is a task-oriented and you need a lot of skills to do it. And that has shown by this wonderful talk from you, from the basics to the advances and what is going to be in future for the best delivery of the radiation dose to tumor and sparing the normal tissue by brachytherapy. So thank you again. Now Afomp, just I will talk about the Afomp. Afomp is continuously doing a lot of activities to uplift the education and training. And the next in this series is Afomp School. And this is a special Afomp School webinar. And this will be jointly organized by AAPM and Afomp. And this is a Global Research and Scientific Innovation Committee, GRSIC, which has been formed by the AAPM and very actively coming up to add on to the research and involve the developing countries. And this Global School on Research Excellence will be on 14th May 2022 during 6:30 a.m. GMT to 9:30 a.m. GMT. And it will be delivered by Dr. Robert Girard, who is a very well-known medical physicist researcher, and by Dr. Magdalena Carter. And the topics will be how to write review papers and how to write review grants and so many things. The registration is on. The link and details are available on the Afomp website. The routine, our Afomp School webinar, that is of 5th in this year and 12th one from since June 2021 and that will be targeted radionuclide radiotherapy and personalized dosimetry. And this will be moderated by Dr. Chai Hong Yong, who is the chair of the PRC of the Afomp. And there will be 5 speakers in this Afomp School webinar, which will be on the 21st May 2022. Details are on the Afomp website. Again, it will start in the 6:30 a.m. GMT on 21st May. Again, we have on the 3rd June 2022 a Afomp webinar, and this will be on nuclear and radiological emergencies, a role of medical physicists. Role of medical physicists can play a multi-dimensional role, and in case of a nuclear radiological emergencies, he has a big role to play. And this talk will be given by Dr. S. Murli Iyengar, who is one of the expert of the nuclear and radiological emergencies at Atomic Energy Commission India, and it will be moderated by Dr. Then we have the 22nd Asia Oceania Congress on Medical Physics during 10 to 12, Adapt to Change, Explore Together. And already the website is functioning. The abstracts are being invited. The website, please visit the website, submit your abstract, and this will be in a hybrid mode. If you can attend in person, you are welcome to attend in Taipei, Taiwan. If not, you can join virtually also. And Afomp will give the travel grants to young medical physicists to participate into this important annual meeting of the Afomp. Further, we have a World Congress in Singapore from 12 to 17 June, which will be held in a hybrid mode. So this is a triennial World Congress which was supposed to be held in 2021, but due to COVID, it has been postponed and it will be held in 2022. So you will take advantage of this thing. Afomp has started many awards, and they will be announced for best PhD, PhD in radiobiology, best publication, the outstanding medical physicist, best publication in the journal, travel grants, orations. All these will be announced on the Afomp website because they are decided and given during the AOCMP 2022. So please have a look at the Afomp website for all these details. Afomp also brings out the Afomp newsletter, and the newsletter is released by 31st May of this year. So please do send your any article, any information, any achievement, any scientific program you are arranging, so that we can include into the Afomp newsletter. Thanks once again for joining in large number. Thanks to today's speaker, Dr. Joel Poda and Jeevanshu Jain, who has conducted this webinar very nicely. Thanks to Jin, who is the chair of the Education and Training Committee Afomp. Thanks to Chai Hong, who is the PRC chair and looks after all the CPD accreditation, certification, all. Thanks to Rajni Verma for the circulation, webmaster, all those things, and again speaker and this thing delegates. With this thing, I conclude today's Afomp webinar and look forward for your large participation for the special AAPM Afomp School webinar on 14th of May, and after that again routine Afomp School and things. With this thing, thank you each one of you for participating, joining, supporting this activity. Thank you very much. Have a nice day, nice time.